The purpose of today's hearing is for all of us to learn more about what a community mental health center actually it is, where it came from, how it came about, and how it operates. The person who's going to talk to us about that is Jerry Mayo, who until recently was in charge of a community mental health center. And my hope in asking Mr. Mayo is that since he is no longer connected with a particular community mental health center, that he has a bit more freedom to speak more broadly about the operation of the centers without being tied down to any particular community health center or group of them. And I've asked Mr. Mayo to briefly give us sort of a history of where they came from and how they came about, and to tell us the mechanics of how they operate, who the governing authority is, and then to talk to us some about the mechanics of how you run one of these things. How do you get enough money to keep the doors open and provide services? And so, Mr. Mayo, is it basically was that close enough to what we talked about that I can get, okay. So do you want to come up and talk from the microphone? And I'll just let Mr. Mayo speak to us and conduct things the way he wants to, and then I think he'll be nice enough to ask questions, answer questions.
First of all, thank you for letting me be here. And when he makes the comment that I'm recently unemployed by a mental health center, it's been 5 years. So, and this is the first coat and tie I've had on in 5 years. So, but I do welcome the opportunity to speak about community mental health, and I can probably talk about it as long as you'd like to sit here and listen, particularly from the business aspects of it. I was a CPA and was hired by Pine Belt Mental Health as their financial officer initially in 1991, became the director in 1998, and served in that role up until 2018 when I retired, and began working with Mr. Rosamond with the Office of Mental Health Accessibility shortly after that position was established, doing financial analysis and looking at the mental health center's financial statements and making comments and recommendations and so forth. So I have a good bit of history to it, but it's, again, what happens on a day-to-day basis, I think, more than adequately explain, and probably can tell you more than you want to know. Hopefully what I'll do is sort of paint a picture of what goes on and then open it up for questions, and hopefully I can be sure to touch on what you want to know. Senator Bryan asked me to speak about how all this came about, and in the mid-60s, there was federal legislation that created community mental health centers. And the concept was that you would have one of these in your community all across the nation. And in the early 70s, the state created legislation that allowed counties with common interests to go together and form regional commissions, is what they were called, to provide mental health services. And in Mississippi, as opposed to some other states, we're rather fortunate that the Department of Mental Health really serves all bodies. It serves mental health, it serves A&D, alcohol and drug, and IDD populations, and are all under one roof. Other states are not organized in that fashion. And when these things started in the early 70s, they were 100%, to my knowledge, obviously I wasn't around, but it's my understanding, they were 100% federally funded with grants, expense reimbursement grants. You spent $1, they gave you $1. You filed it and they reimbursed you for that. One of the prohibitions is you could not own buildings. They would not allow you to spend any of that money on capital. As time went on, particularly in the early 80s, these grants began to disappear, federal grants, and they became funded with state money, and then gradually through the 80s, late 80s and into the 90s, Medicaid became the primary funder of community mental health. And that's the situation today. Medicaid funds is the largest payer for mental health across the nation. And what community mental health centers are, or what they do, is they're essentially businesses embedded in government. Our boards of directors, as I mentioned, the counties go together and form these regional commissions, And the boards of supervisors appoint members to serve as the directors of these commissions. Those appointments are identified based on a number of different ways. Sometimes people just volunteer. Sometimes they have people involved in our services, a citizen, and they'll ask to be on them. Occasionally, I would have boards of supervisors call me and ask me that I know someone that might be interested. But those individuals serve as our commissioners. They're a governing body, if you will. And as I mentioned, a mental health center is a business embedded in government. The only distinction between what any other business does and what a community mental health center does is mental health centers do not pay taxes, and a portion of our funding comes from grants. As opposed to your local tire store, they buy a tire and sell it. And it's a transaction that's very simple. In a community mental health center, we provide a service which is measured in increments of time, and we bill somebody for it, or there is a grant awarded to us, either through the federal government directly, through federal funds through the Department of Mental Health, or state funds through the Department of Mental Health. And those grants are either expense reimbursement or fee for service. In Mississippi, the legislature does not give us any money. They do not appropriate $1 that comes to us directly out of the legislature. It goes to the Department of Mental Health, and the Department of Mental Health awards grants to us. And last year, I think there was roughly 500 different grants given to community mental health centers for a total of $81 million, of which about $75 to $76 million was actually expended. But primarily, and again, that makes up about 30-something% between federal and state grants of our total funding. Medicaid makes up about 52% of our funding. And those billings take place based on services that our employees render. And again, those services are generally delivered in increments of time, 15 minutes or an hour, in some instances by day. And Medicaid reimburses us for that. The rates that Medicaid establishes are basically 90% of what Medicare will pay for a service. Medicare pays for the same services for Medicare eligible individuals. By statute in Mississippi, what Medicaid reimburses to us and every other provider is 90% of that Medicare rate. There are a couple of other services, a few other services that Medicaid sets the rates for themselves that are reflective of cost, designed to reimburse the cost of that service. In Mississippi, and again, the mental health center, as I mentioned, you do not provide any direct appropriation to us. It goes to the Department of Mental Health, and the Department of Mental Health gives us grants to which we provide services based on some contractual agreement. We send in reports, they send us money, we get audited, and basically that's how that transaction works. And again, there's two forms: fee for service, which means we provide a service and get that money, or cost reimbursement, that we're providing a service, but they're paying for the employee's time, their whole salary, and those employees are doing what the grant requires us to do. Those grants are generally very specific as to what they do. They're not available for the general population. They're generally, there's a few federal grants that are more broadly based where we can use them for a larger segment of the population, if you will. But most of the grants you get from the state are very specific about what they can do and who they can treat, if it's indeed a treatment grant. And the money that a mental health center generates, it's responsible for every business function that every other business does, whether it is compensating employees, providing their benefits, building buildings, providing vehicles, doing anything that's necessary to operate that business. And I'll contrast that against one of the state agencies where they have other agencies to call upon to provide human resources, to provide IT expertise, buildings and grounds, and what every other service may be necessary. Mental health centers do not have that. Back around in the early 70s, there was initially 15 community mental health centers across the state, and they varied from the size of one county to up to, I think initially 10 counties was the biggest one. The federal legislation to qualify for those grants required a mental health center to be at least serve a population of 75,000 people and no more than 250,000. So that gives some insight as to how the mental health centers were initially formed, because they had to meet those guidelines in terms of size. Now, the guidelines eventually went away, and there's no limit today on how big or small a community mental health center can be. Again, starting with 15, and when I came into the service system in 1991, today there's 11. There's 1 in 5 were incorporated into 6 regions, what is called Region 6 now. Region 12 picked up what was Region 13, and then Region 11 has been split between Region 15 and Region 12. So we've gone from, some still have 1 county. Hinds Mental Health is 1 county. And then Region 12, I think, has 18 counties, and Region 6, I believe now is up to like 15 or 16 counties. So there's some very large ones now. And again, there's one that's just 1 county. And what counties are important, because it's geographic management, if you will, you have to manage a larger area. Just as important is the size of the population that you're trying to serve. I think Region 12 has about 700,000 people now in their catchment area that they're trying to deliver services to. And some of the other regions, I think the smallest one's around 120,000 now that they're providing services to. In terms of population served, what's really interesting about this is that Medicaid makes up 52% of the money, and about 38% of the individuals served by community mental health centers are not Medicaid. They are what I refer to as under and uninsured. Hey, Senator. Or underinsured, meaning that they likely do not have a payer that is going to pay for the services or the cost of the services that we provide, which is problematic for a community mental health center. Most of the services in Medicaid come close to covering the cost. Some of them do not, but the synergy of all the services you provide in Medicaid cover the cost of providing services to that population. The uninsured and uninsured, there's no way to pay for all of that. We get money from the grants, as I mentioned before, and some portion of that population may fall under the criteria required for those grants and get services. In addition to what we get from Medicaid and the county, in the Department of Mental Health, as well as some direct federal grants that some of us get, or some of us did get, or some of them do get, because I'm not one of them anymore. We also get county contributions from the counties that we serve. That amount was established in the appropriation bill, Department of Mental Health's appropriation bills every year, and it's actually tied to some amounts from 1982 and 1984, which are really pretty much irrelevant today. Most of the counties far exceed what they or do exceed what they would have been required to file in 1982 and 1984. It amounts to about 3.5% of our total budget if you look at it across the whole service system. It's about $9.5 million, something like that. And it's important money, but it is not necessarily designated for the uninsured, nor does it cover necessarily the cost of providing care for the uninsured. But it is a critical part of what we do. When you look at community mental health centers and what their challenges are, obviously the uninsured and underinsured population is one of them. They, there's not enough margin in what you do in Medicaid to cover the cost of services that all those individuals need. County contributions are a start toward doing some of that work, as well as some of the grants, again, have specific populations that fund those, allow us to fund those services. But overall, the uninsured and the underinsured are problematic. And when you look at the challenges facing community mental health centers, one of which comes from competitors. When I say competitors, they're competitors in the fact they're certified by the Department of Mental Health to provide services, but they're not competitors in the sense that they do the same thing we do. In Jerry Mayo candor, they cherry pick the populations they want to serve and the services they want to provide, so they maximize their reimbursement and their margin. which leaves more for the community mental health centers to have to absorb in uninsured care. By doing so, it also allows them to compete quite aggressively for our staff that we've trained, but they can pay them more because a higher percentage of the people they serve are getting reimbursed. One of the challenges in a community health center now is being able to adequately compensate staff and retain staff. And I looked at just briefly this morning, total positions budgeted in community mental health centers right now are about 4,400 positions. And that was through September. That was at September 30th, the last time I looked at their quarterly financial statements. There were 223 vacant master level positions out of that 4,400 positions. 223 people that were not working, that needed to be employed. There were 33 nurses that were in vacant positions. A lot of those nurses are required to operate CSUs, the Crisis Stabilization Unit. And without a nurse, you have to close beds. So those are critical positions. And then there was 275 high school positions. Again, for what most of the community mental health centers are able to pay, high school positions are undegreed, if you will. They can work at Walmart, Target, fast food, and make as much, if not more. So it's a very competitive market. Altogether, there's about a 15% vacancy rate out of the 4,400 positions that Medicaid, that Department of Community Mental Health Centers have budgeted. What I'd like to do now is, again, I think to reiterate, they're businesses and they sell time is how we make our living. We're on a kill what you eat model. We have the ability to generate revenue, but that revenue has to be sufficient. And the way you generate revenue is against the fixed reimbursement rate per hour, whether it's Medicaid, Medicare, DMH grants in some instances, or whoever it is. And so you have to have the ability to generate, you have the ability to generate some money against the fixed cost, against the cost of what you have to pay employees. And when those get out of balance, then that gets to be difficult for a mental health center to be sustainable. And I've said a lot. And so I think probably what I'd like to do is just stop and see what questions you might have and go from there and fill in the gaps and clarify what I've said that wasn't correct, whatever it might be.
Well, listening to your presentation about the finances, it reminds me of someone trying to operate a community hospital, in the sense that if you're a community hospital, county hospital, you're trying to take care of the needs of the people in a certain geographic area who need to go to a hospital, more or less. If you're running a community mental health center, you're trying to take care of many of the mental health needs of the people in a geographic area. And you got to finagle a way to get enough money to do that. The reimbursements don't necessarily coincide with the cost of providing services. The reimbursements are not always large enough to pay for the cost of services. So you have to mix and match. You get some money from the county, you get some money from here, yonder, and there, and you hope that by the time you get the various sources of revenue together, you can then provide the services that you feel like you should provide. And one of the problems is that people who could come to you for services can go somewhere else, and there tends to be a situation where those who cannot afford to pay all come to you. Those who can afford to pay sometimes come to you and sometimes go to another provider. It just seems to me like there's a lot of overlap between the financial structure and the mission of a community mental health center and what we used to have as a community hospital. I also would just mention that I've told people from time to time a community mental health center is like a junior college, in the sense that the state's divvied up into districts. We've got boards that are appointed by boards of supervisors. They all have theoretically the same um, mission, but not all junior colleges are alike, and not all community mental health centers are alike. They vary based on things such as who's on the board, and it varies greatly based on who they hire to be the person in charge, whether it's a community college president or the community mental health center director. So I don't know that those are questions, but Hannah Miller at this point used to say, and my question is, don't you agree with me?
You know, one of the things that I didn't mention, sort of along those same lines, is mental health centers are very unique in terms of when you compare it to other businesses, which is what I like to model it or do my comparisons with other businesses. As a business, the tire store has a customer, and a mental health center has more customers than you can shake a stick at. Stakeholders are people that are interested in what we do, whether it is legislators, every board of supervisors, every law enforcement agency, every school district, every school principal, and every county that we serve, plus others, all have their special requirements, if you will. And in my observation in the time that I spent in mental health is what they all wanted you to do is solve their problem, most of which don't want to pay anything to do it. And so you have to go back to the source of funds you have, which may be Medicaid revenue, maybe some county contributions, maybe grants from DMH, to try to make those work together. And when you talk about Medicaid revenues, all regions are not equal. I mean, when you look at the populations, if you look at some of these regions and the populations, there's one region that 42% of its population is Medicaid eligible, as opposed to the lowest one I see here is 19% is Medicaid eligible. So even the people that walk in their door, if 100 people walk in their door, there's a disproportionate representation of how many of those are going to have a payer and how many are not, which makes it even more challenging. There's actually 2 regions in the state that serve more non-Medicaid individuals than they do Medicaid. So it makes it incredibly challenging to get all the numbers to work together in synergy to meet all of these needs. And as over the last several years, salaries have just gone up tremendously, which has been well documented in the press, and it's no different than what's happening in these mental health centers. They're having a very hard time competing, particularly for master's level staff, nurses in particular, which makes it that much more difficult to hold the workforce in place necessary to deliver the services that are needed, and in some instances are required. I mean, they really got to be done. Mentally ill folks do not get better with the passage of time if you don't treat them. If you ignore them, it gets worse. So they're going to demand treatment, and they demand attention to be able to function in the community. And when they are adequately treated and medicated, they can do amazingly well. Maybe your neighbor and you never know it. So, I mean, it's a very challenging environment that they operate in on the best of days. Today, in this environment, it is probably more difficult. I'm not sure that I could do it anymore. I enjoyed it when I did it for 20 years. We made a lot of difference. We were able to grow, offer a lot of programs. It fed into my business inclination, but I don't mind telling you, today's environment, I'm not sure I could do this anymore. Other questions?
Sure, and I think what we're doing right now is we're trying to talk about the structure and the finances and all of that. And I think later on, we'd like for you to talk about some of the specific services and all and the things that you provide. But I used up all my question time on just one question. Chairman Creekmore, do you have questions?
Yes, sir.
Thank you for your service. And, I've just learned to appreciate the value of the CMHCs in the state of Mississippi over the past few years. You briefly mentioned about the school systems and how we need more people in there, but you didn't talk about that service. Can you explain how important and how the community mental health centers interact with the school systems?
Yes, sir. Over my tenure, it evolved from a time when we actually had staff doing individual therapy in schools. operating day treatment classrooms for special, and when I say special needs, I'm talking behavioral needs, not IDD. Offering day treatment in those classrooms. And at one point, we could not meet the need for all of that. We could not hire enough staff to do it. It has evolved to the point now, for the most part, because it's not all, the state's a big place, and there are different pockets of how people are able to deliver and maintain relationships. School systems became one of the primary competitors for our staff. Rather than have our staff come in and provide the service, they would hire our staff. And of course, if we had 4 or 5 people working in a school district, or maybe even a particular school, they could pick and choose the employees they wanted, and then they would offer them more salary than we could pay and a school-based schedule. Very, very hard to compete with. The mental health centers still provide a lot of service for school-age children, and a lot of times that is outside the schools in terms of psychiatric care. A lot of the medications and a lot of the kids, particularly Medicaid kids, will see our psychiatrist or their psychiatrist and nurse practitioners for their medications. We still have counselors that go into schools to some degree. We have community support specialists that go into schools to provide services. But the day treatment classrooms are far more difficult to maintain now. The services that takes place in a school are largely determined, interestingly enough, by the school principal. It is not the school superintendent. The principal gets in there and makes an assessment of what they need. They ask for those services. We have memorandums, or the mental health centers have memorandums of understanding with all the school districts that they're available to provide whatever they need. And the school principal really defines and designs what services they want, and then the mental health center responds to it.
Are there school systems that reject your services?
I'm sure there are, yes, sir. And reject is a strong term. They may not allow staff to go into the school. However, they're certainly willing for those individuals to come to our offices to receive services or to receive particularly medication services. I don't doubt that there's schools that, and I will also say this, there are schools that would allow other providers in at the exclusion of the community mental health centers.
And I don't mean to get out of the purview of the purpose of this meeting, but I would like to ask for your perspective, how the process by how you receive a patient, the process of how it comes to you, whether it be from the chancery or from the sheriff, you can just go through that and what you think works best. And then 2, and you may want to answer this one first, how many, or percentage-wise, how many people just come to your office for a visit and then go home, and then how many stay the night?
Well, when you say stay the night, community mental health center, depending on which ones they are, we're not all quite the same. We have crisis stabilization units. Most all of them have one now that range from either 8 beds to 16 beds, and there's a couple of regions that operate multiple of those. So that's stay the night. There are also a number of residential programs that the community mental health centers operate, that this is where the individuals live 365 days a year. They live in a supported environment. Some of them possibly have apartments that they live in that are owned by the community mental health center, but again, they receive the services they have frequent contact with the community mental health service personnel. So when you talk about the numbers, it's a very small number. I think we served 84,000 people last year. So when you talk about those numbers that people stay overnight, whether it's residential or in CSUs, it's a pretty low number relative to 84,000. Most of the people that we see are outpatient visits. How we get those individuals is any way that you can imagine. Referral from a school system, referral from a chancery clerk, walk in the door, referral from a family physician, referral from somebody else that's already in our services that knows these individuals. You know, in 20 years as executive director, I was amazed every morning somebody was standing at our door that was new. Blew me away. I don't know where they all come from. I don't know why we didn't already treated them, why they hadn't been in our services. Every day we had new people walking into our services. But they come from any number of ways and any number of referral sources. And I don't know that I know anymore. At one time, we kept stats on that about how people got referred to us, but I can't honestly tell you now that I can repeat what those were. But there was no shortage of individuals coming in for appointments. New people, new intakes.
But probably 90% receive the treatment and go back home.
Oh, yes, sir.
Yeah.
And it's outpatient services. The majority of what we do is outpatient services.
And that's what you prefer anyway. I mean, you want them to go back to their routine and be
Well,
productive citizens.
When you say prefer, that's really the only option. You cannot house 84,000 people on any continuum basis for treatment, nor do they need it. Most people function very, very well in the community with appropriate supports and medication. Now, again, I'm not a clinical person. There are clinical people that could really tell you a whole lot more. But my observation as a business person running this, again, 95% of the people we treat can be maintained in the community. Some of them hold jobs, function very, very well. It's that you might think of it as the 90-10 rule. 10% of the people create 90% of the issues and the need, really, really intensive needs. Most do not.
Gentleman from Harrison.
Thank you, Mr. Chairman. Mr. Mayor, I appreciate your service, appreciate you attending today. I have a few questions. Two of them center around the regional system. Number one, we've seen the collapse, I think, of three of these. That would be 1, 11, and 13. Does that sound about right?
Yes, sir.
And we see that the lion's share of those have been pushed to 6 and 12.
Yes, sir.
Are 6 and 12 going to be expected to take on any more counties?
That's a good question. First of all, 1 was not pushed to 6. They were negotiated that between themselves, really. 1 approached 6, is my understanding, and said, you know, we're going to need to do something. Can we work this out? 13 and 11 were unsustainable. I don't know that they voluntarily wanted to do anything, but there was not choice. How well, my observation, and these are recent, 13 and 11 going in 6 and 15 and 12. How well that's going to work would be proven over time. That is a very large geographical area that you're trying to manage. And as I mentioned, every county that you add brings a whole new group of stakeholders that have their own interests, own demands, and not necessarily proportionate to resources. I don't know that there's any plan that I know of to ask any region to take on any more counties anywhere in the state. And if you, in my mind, if you were to approach me as a director and say, would you do this? You have the option to say no, yes. And the counties have to agree to accept it and or reject it. But there's no preconceived notion, to my knowledge, of any counties going to any other regions, and specifically for 6 and 12 to be adding on counties. There's been no conversation that I'm aware of around that.
My second question in regards to the regional system, do you think that's the one best way for the state to operate, or do you think there's another best way?
You know, I've seen one system, and we made it work quite well. It's a different environment. It was 5 years ago. There are states that are not organized on a regional basis. I happen to be a part of a national organization when I was working that we met every quarter, so I got to talk to other people from other states about how they were organized. Some states were organized around service line. All this CMHC did was case management or community services, community support's what it was called, or all they did was psychosocial programs. All they did was residential services. They didn't do all the support services that were required to maintain somebody in a residential. If it works best or not, I can't answer that for you, what is best. We have seen this work. It has worked. And I think probably, if it were me, again, a background in business, as opposed to figure out, the real question for me would be, why did Region 11 and Region 13 not make it? And how do you mitigate those risks in the other mental health centers? So that when you walk away with strong mental health centers and try to avoid the risk of Region 13 and 11.
Okay. And my final question is, the roles that CMHCs play in the pre-screening process. Can you touch on that real quick? Do you think that there's improvement upon that, or do you think their roles currently are exactly what they need to be? We're seeing people end up in jail, in some cases, unfortunately die. And maybe, but for some better pre-screening or something in that regard, that would not have happened. Can you touch on that?
Yes, but again, let me emphasize, I'm not a clinical person. That was not a service that I had hands-on in. That was clinicians, clinical staff performed all those functions for us. And the way that worked was, again, they acted on a pre-screen based on sometimes what people were telling them. Family member comes in and tells them, my son is doing this and my daughter's doing this, and they're at risk of harming themselves or someone else, or inability to take care of themselves, which is basically the commitment criteria. And everyone who does that pre-screen has to make a decision whether or not they warrant an evaluation. And so they do, and then the individual is picked up to be evaluated. And that evaluation then is by, again, this may have changed slightly over the 5 years, but it's a doctor, psychologist, or a nurse practitioner. And two of those individuals, one of them having to be a doctor, does a psych eval and makes a recommendation whether it goes on from here to commitment into a state facility or not. And then it goes before a judge and does that. The whole process, there's risk for error in that. But I don't know a process where there's still not going to be risk for error in decisions. In my experience, we could actually evaluate people and recommend commitment, and the judge disregard that. On the other side of it is recommend they not be committed, that they don't need this level of care, that they could be served in the community, and the judge still commit them. So I'm really not sure that I can offer any really constructive comments about how to make that better. It's a difficult process. It's very intrusive to individuals. Not to mention that can result in death. I suppose you have specific examples of that. But I don't know that I'm in a position to really offer any real good advice as to how to address that. There are others in the system that are clinical, that may be able to do that. That's really not something I would feel comfortable trying to make a recommendation on.
Thank you, sir.
Those of you who were here a week ago will remember that some of us were above the rest of you. And this week we have come down from above to dwell among you. But there is still a head table. So does anyone at the head table have a question? Seeing none at the head table, we will now go to the others. Senator Wiggins.
Thank you. Thank you, Mr. Chairman. I appreciate being recognized as another. So my questions are going to be a little bit along the lines of my colleague, my esteemed House colleague from Harrison County. And I appreciate you coming to speak with us. I guess the heads of these CMs, these community mental health centers, it's accurate to say that when you're talking about pay for the directors, we're getting into the 300,000s or thereabouts. Am I not correct in that?
My observation is, yes, that is the case today. It was not in my 5 years that I was here. I never quite achieved that when I was in my 20 years.
And would it surprise you to say or to hear that it's this system is not working in parts of the state?
You know, I mentioned earlier the number of stakeholders that a CMHC serves by every county. And I don't doubt that there are places where you can find any number of people would tell you that it's not working. But out of 84,000 people we served, I would suggest to you it worked for 83,000 of them. So when you think about those where it is not working or is categorized as not working, I'm not real sure what that means. Again, down to my experience, my own 20 years as director, I had people complain every month about something that did not work well from their aspect. And it was sometimes quite discouraging because despite our best efforts, we could not meet the needs or the expectations of those persons. However, there was another 12,000 that did not complain. So it would never come, I cannot imagine a system that serves 84,000 people, 82 counties, no telling how many school districts, families that would not have deficits. It's a matter of what those deficits are and how best to address them and really try to source the source of the deficits. So no, it doesn't surprise me. However, I tend to focus, there's a lot of good going on as well.
Well, and I appreciate that. And I think you're from Pine Belt, and my information and from what I know, Pine Belt actually is very good community mental health center. The problem is down where we are, it ain't good. And in Jackson County, the director was forced out. They weren't taking people, and Jackson County alone is investing $3 to $4 million to build a mental health facility because Singing River Services is not helping. They get no cooperation from this region that's been set up. And it appears over time that since the 1970s or whatever, when this was set up, that people have their favorites or it's the way it's always been done. And to my colleague's question, they went under. And so at least in South Mississippi, it ain't working from this level. And there's people making $300,000. And you got people on the street, you got the jails filled with people. You got the courts in Jackson County, they had to do an ombudsman to investigate this. And that's, I think, part of the issue is that people have their favorite. And we've been doing it since the 1960s, and we're going to continue to do it that way. And I think where my colleague was going was we need to look at something different because at least where we are, it's not working. And this isn't from people who've been served and just aren't happy. This is from numbers and the county governments and things like that and investigations. So if you can point me in the right direction to where we can go to find somehow to do this differently, I would love to have that information.
Well, and again, I don't have a lot of knowledge about what you're talking about. I do know some. And my first observation is yesterday is yesterday. And the people that were there are gone. And today's an opportunity to do it different and better. And when you talk about who has favorites and who doesn't, I have no knowledge of what that means or how it applies on a day-to-day basis and operate. But communication of whatever those deficits are and whatever the expectation is would certainly be the starting point and work toward accomplishing those things. I just don't know enough about it. You know, in my role, I spent a lot of time in problem resolution, obviously. And it got down to a lot of things about communication, what I can do, what I can't do, what do you want versus what you need, and how can we reconcile those things. But without specifics, Senator, I'm just, in being involved in it very closely, I'm not sure that I can help you. And even the term favorites, I don't know what that means in application of day-to-day functioning of a mental health center.
No, I appreciate your role, but, and I guess to answer your question about the favorites, it's that it seems to me like when something's not working, you look for new solutions.
I agree.
And it's not working where we are. And when we, and I personally, and I think some others have put forward some ideas and they get lobbied against and they get, worked against and things like that. And so we just got to do better, like you're saying, and communicate, but we can't keep doing what we're doing. And I guess my point is I don't want to paint a rosy picture because at least my experience and where we are, it's not a rosy picture. And when I guess it was Region 11 collapsed, there were thousands and thousands of people without mental health services. And the boards of supervisors had to call emergency meetings because the community health center, who everybody relied on and they had contracts with, went under. We can't do that. We
Agreed.
can't continue to operate like this. Thank you very much.
And that's part of the function of Mr. Rosamond's office is try to identify that before it happens and try to make, I think one of the charges of that position is to try to mitigate the chances of that happening again and try to make plans for it. But I can tell you, even making a transition, even with a plan and a transition that we're going to do this and this and this, and we're going to move these counties into this region, every bit of that is problematic. It is not easy to do. It is time consuming. And when you move, even today, they hire a person, they hire a therapist today. For that person to reach their productivity, it takes 6 months for a staff person to get there. The training curve, working with the population, doing the things that's necessary. If you get there in 6 months, you've done a heck of a job. Hopefully you keep the person for 6 months. They don't leave and go somewhere else. The turnover in a mental health center is something around 20 to 25% a year. So it's a challenge to do that. I don't discount what you're saying at all. I mean, if something's not working and not working can be defined, then you can work toward a solution with the people as long as everybody's working toward the same goals and the goals are adequately identified and measurable.
Representative Thompson.
Thank you, Mr. Chairman. Thank you for being here today. I have 2 questions for you today. As we look at Region 6 and Region 12, looking at the landscape, my first question is, how do you plan to manage to put enough staff, and we already have a crisis with staff, since they have increased the size of the region?
And the question is, how do we get and manage staff?
Right.
Excellent question. As I said, I've retired 5 years ago and I don't have to do this anymore. And I don't know that I know the answers to it. It's going to take a great deal of middle management to be able to fill those voids. And we're plowing new ground in terms of what is an ideal size for a community mental health center. The 2 centers that took this over are very strong centers, financially and clinically. And what you hope to do is be able to take what they've accomplished and what they've learned and be able to integrate that into those other counties and the staff that you hire there. But it's a process. It will likely be a process that takes several iterations to get correct, but it is going to be a process to be able to successfully get that accomplished. And it'll be time to do that. You're going to have middle management, strong middle management to be able to get it accomplished.
My next question is, looking at this large area that you're covering, what about the patients that have mental health issues in such a large region? You alluded to that. Everybody have their own political ideas about different things, and that infight may happen, anything like that. What are we going to do about the individuals, constituents that have mental health issues that need something in the crisis time, and look at 6 and 12 in those areas and stuff like that? You're looking at transportation issues, you're looking at, are they receiving medication like they're supposed to make sure they are on task for what you need to do, the goals? How do you plan to address all those issues?
The directors of those will address it, but it's going to work the same way. I can speculate if it were me. It's going to work the same way it works today in any of those other counties. There's medical care that's available to them. There's community support staff that's available to them that are actually housed in those counties or serve those counties. Just like it happens in, I'll use Forest County, Hattiesburg, or the home of Region 12. Just like it happens in Region 12, it's going to happen over there in Walthall County or whatever other county that's in those counties. Same process.
So you're telling me you're not setting anyone up for failure to make sure that we have adequate mental health for those individuals that really need it for such large areas of 6 and 12?
No, sir. There is no plan to set up for failure.
Thank you.
Doesn't take much planning to fail. And I'll assure you that every effort is being made to ensure that it's successful. Now, is it going to be successful? In the eyes of many, it will. Are there going to be the naysayers? There'll be a few. But the eyes of many will get what they need when they need it in the right amount, given time.
Thank you, sir.
I think we have time for 2 more questions, and then I want to move into another area. Senator Blunt. Senator Blunt, you'd be nice to that microphone.
Thank you, Mr. Chairman. How are the boards govern these community mental health centers? Is that correct? They're governed by independent boards?
How do the boards govern them?
Who governs the community mental health centers?
Boards of commissioners.
And how are they determined?
They're selected by the boards of supervisors from the counties within that region.
So in the case of, and this is something that with these larger districts that have been created with consolidation, how many people roughly are on the board in Region 12 and Region 6?
Region 6, I don't remember how many counties that have, but in Region 12, there ought to be 18 board members. I believe they have 18 counties.
So there's one member from each county?
That's correct.
And I think I heard you say that statewide, roughly, the budget for each of the centers gets about 3% of their money from the counties?
If you look at the total budget for the mental health centers, it's something around $280 million. 9 million, 9.5 of that comes from the county contribution, so somewhere around 3.5%. Yes, sir.
And is that determined, is that a fixed amount that each county in the system has to come up with each year? Is it a matching, or is it just whatever, however best the county think they can do?
No, every county does not give the same amount. There is a minimum set in the DMH appropriation bill every year.
Okay.
But again, that minimum is set back based on some 1982 and 84 criteria. So really, they give what they are willing to give toward what they want to receive. The mental health centers go before every county every year and present their budget and their needs and ask for contributions or ask for what their county contribution will be. In some instances, the county may want more services in a particular area and be willing to pay for it, and will make an additional contribution. In other instances, some of the counties give no more than they have to give. So it's sort of, I don't want to say it's a negotiated amount, but it is not a fixed amount, and it is subject to variability. Has a lot to do with the size of the county,
Right.
the resources of the county, and those kinds of things.
And so that, I was about to ask you, are the services provided to a Mississippian consistent across the state, regardless of where that Mississippian lives? It sounds to me like they're not even consistent within the region, depending on what county that person lives in. So if you're a Mississippian who lives in a county that does the minimum contribution that was set 40 years ago, you may have a different level of services available to you than a county that pays more. Or if you live in a region of the state, or services are not consistent within regions or statewide, is that correct?
The services are consistent in every county. The availability of those services, I'll give you an example, is I may have psychiatric counseling crisis in a particular county, but I may have that office only open 3 or 4 days a week because of the size of the county. You can't staff it
Right.
5 days a week. However, they have the same availability of the services that they have in a county with 100,000 people. The frequency may change. And the services that they receive is not dependent upon the county contribution. The services they receive is really highlighted or spelled out. The minimum, if you will, is in the DMH minimum standards or operational standards about what every mental health center has to do and the services they provide. When I say the negotiation amount between a county and the mental health center, the county may want you to do something different, like go into the jail and provide psychiatric care.
Okay.
Well, that requires me to go hire a psychiatrist. It requires me to hire a psychiatric nurse practitioner, and there's a dollar amount assigned to it. So that may be what they do. But again, that's generally going to be a very large county with a lot of need for that particular service.
And
Does that help at all?
it-
It's not negotiated in terms of, we're going to give you individual therapy if you'll pay us this amount of money, but if you don't, we're not going to give you that. Minimum standards or minimum services are provided in every county in accordance with the operational standards of the Department of Mental Health.
But if you're going to be in jail, you want to be in jail in the county that was able to get you that psychiatric treatment and not the county next door that couldn't.
And again, there are ways to get that even if you don't negotiate that. I mean, we actually did some telehealth where we would go into the jail through telepsychiatry and provide whatever county needed. But when you need big blocks of time,
Yeah.
somebody has to pay for that time. A mental health center cannot do anything they are not paid to do. And somehow you have to find the resources to meet the need.
And just, I don't know that you can answer this, and I'll stop after this because I know we have other questions, but I'm interested in the cost of uncompensated care, people who might be eligible for Medicaid, who are not currently eligible for Medicaid, and trying to put a dollar amount on that. I don't know if you have access to that, but I think there's probably somebody in this room who does, and I'd like to get that. So thank you, Mr. Chairman.
Representative Waldo.
So back years ago, when I got out of college, this state job, they were like the lowest paid job of any state job you could find. And to properly staff these places, to get them where they need to be, is the salary of those who actually come in contact with the patient not gonna have to increase before you can ever provide the services that you need to do and the quality of the service that you need to provide? Do you think that the turnover is probably based on lack of pay rather than actually the job itself?
Yes, yes, and yes. You know, one of the things that's missed is the difficulty working in a community mental health center. You work sometimes in different difficult environments. We have people that spend a lot of time in clients' homes. You work with what can be a difficult population, and you work in a difficult management environment in that I'm going to know every day what you did, how many hours you spent with the clients, and then you work against a reimbursement that is not cost dependent. So you can afford to pay what you can afford to pay, and then you evaluate that against whatever the competitors are doing, and what am I going to do to be able to retain my people? So you try to inflate those salaries. Your question, if it's the lowest paid people dealing with the clients, that is not the case. In fact, some of the highest paid individuals we have are psychiatrists and psychiatric nurse practitioners, which I wish I could get them to spend every minute of every day with a patient, because they're critical to their care. So most of the people, and again, you're probably thinking about the fact I said we had so many high school vacancies. Some of those are support people in residential programs, day programs, drivers, those kinds of roles. Clinical roles are provided by clinical staff. Did that help at all? Okay.
Thank you. Before we move into another area, I would just mention in passing that everyone we talk to in any area of healthcare talks about workforce. It's just a problem. We're making some moves in the right direction, but I think that's going to continue to be a concern. I would mention that the various community mental health centers were formed voluntarily by the various counties, and the counties have the ability to move from one district to another. If you'll look at the districts as they existed in 2009, and then look at the districts as they existed in 2020, and look just as close to Memphis as you can get, right up there in the northwest corner of the state, you'll find DeSoto County. And you'll notice that in 2020, it suddenly is a member of District 4. Well, District 4 is over there in the northeastern part of the county and part of the state. And DeSoto County was unhappy with their situation in District 2 and just up and moved to District 4. That happened sometime between 2009 and 2020. The other comment I would make is that community mental health centers got started by federal legislation based on the notion that we had many people who were institutionalized who could be better served in the community. And the community mental health centers were the method of providing community-based services to individuals. Lots of things have changed since then, but in a sense, we're still at that same position, which is, to a very, very large extent, the community-based services, which we all want to provide more of, are provided through community mental health centers. So having said that, Mr. Mayo, could you just go over some of the various services that a community mental health center provides, and sort of a picture of that?
And this tends to be a rather esoterical conversation, because when I tell you individual therapy, most people, unless they've participated in individual therapy, doesn't really know what that is. But, you know, probably the highest service that is offered in a mental health center is psychiatric care that are provided by either psychiatrists or psychiatric nurse practitioners. Again, you associate that more often than not with a prescription of medications to address whatever need that you have. You know, past that, we go to therapists, particularly master's level therapists that have sessions with you. And particularly, I can equate this to a seriously mentally ill individual that has any number of needs, whether it is food, housing, depression, whatever they need, need individual help with. A clinician would spend time with that individual doing that. Another one is community support services. These individuals actually are in the community, working with the clients, going into their home. Did you take your medicine? Are you paying your bills? Do you have enough to eat? Are you at risk of being evicted? Do you have housing? Those kinds of things to try to meet their everyday needs. Mental health centers also have crisis services where you call and somebody comes out or talks to you or does whatever's necessary to help you mitigate that crisis. They have psychosocial programs, which are day programs for adult seriously mentally ill, where somebody can go to a program and stay all day long. They get a meal, they get transportation to it. And by the way, the number 2 barrier to healthcare in Mississippi was, and I assume it still is transportation to get to services. And Medicaid provides transportation, but over the years, that's been, I think it's better now than it was, but it was sometimes unreliable. Then in terms of children, same kind of services in terms of individual therapies, case management, where they go in the home of the child, go into the schools and provide therapy for whatever is the child needs. And again, a clinical person can more adequately describe what actually transpires in those services. There are particular programs that are funded by the Department of Mental Health that target specific populations. One is PAC, what's called a PAC team. It's a program for assertive community treatment where individuals that meet that criteria of care, which are generally going to be individuals that are seriously mental adults that are high risk of hospitalization, are treated by a team of individuals, which will include a medical person, a master's level therapist, community support staff, as perhaps others, and they're treated by a team of individuals. And the whole objective is to keep that individual in the community with the treatment that they need. And I guess that's an overview. I can't think of it. And all that dealt with mentally ill. We also have a whole continuum of services for the IDD population, a lot of which are day services. IDD is intellectually and developmentally delayed individuals. And then we have the same kind of services for alcohol and drug and addiction, some of which is a residential program that I think, I want to say all but one mental health center may have that, and they contract with somebody to do it. And they also have outpatient alcohol and drug treatment for individuals. Is that a clinical person can give you a lot more on that than I can.
Then there are the crisis intervention or crisis stabilization units, which.
Yes, crisis stabilization units, which vary from 8 to 16 beds that are really serve as a replacement for inpatient hospitalization at a state hospital. They're 24/7 care, medicated staff by RNs, techs, as well as doctors and nurse practitioners. It's like an inpatient hospital for the mentally ill.
And I think one of the goals of crisis stabilization units is that they are a de facto and real world alternative to jail and a de facto and real world alternative to the state hospital.
That's correct.
That's the niche they're supposed to fill. Questions from?
And individuals can enter that through, they can walk up to the door and ask to be evaluated. They can enter that through referral from Chancery clerks, from referral from the communal health center, from referrals from law enforcement. They can be court ordered into it. So there's a lot of ways to get into that service when that service is warranted.
Questions? I don't see any questions, so thank you, Mr. Mayo. It's been very helpful for you to talk to us about this. I would just say that one of the dilemmas that we face that we're all struggling with is providing services in the community, in the real world, services that actually exist, that are there, are available and easily accessible. We do that through community mental health centers. And when we've got a number of these facilities, each with its own board of directors, each with its own funding situations, there are just going to be variations as you go from place to place in the state. And a community mental health center, if you look at these areas, the community mental health center is like the school. It's a part of the community where it is. So what a community mental health center does, in fact, depends on what the police in that area are doing. In fact, it depends on what happens down at the Chancery Clerk's office. All of this is so interconnected. And one of the struggles we're having is to try to provide better services and to try to make sure that there is as high level service as we can provide for everyone in every county. So I think that's sort of a summary. And thank you again, Mr. Mayo. I think it's been very helpful. We will meet again Monday at either 1 o'clock or 3 o'clock, whenever Chairman Creekmore says we're going to meet. We'll meet down below, down in the room with the big column that supports this room. We'll have a presentation from Wendy Bailey, who's the head of the Department of Mental Health. I think it's an appropriate time for her to come and sort of give us an overview from her perspective of the various things we've been discussing about mental health. And as Representative Creekmore pointed out, the House members didn't get to hear the initial presentation that she made. And I think that at that point, as far as the hearings are concerned, that'll sort of wind up the mental health portion of the hearings. Of course, this issue is going to go on through the session, but the session that we'll be having again next week at 3 o'clock in this room will be about a different topic. And having said that, thank you all for coming.
You didn't miss a lot.